Welcome everyone to our session today on no universal health coverage without gender equity. What does the evidence say? And I'm delighted to welcome our panelists, Dr. Sarah Sally, Dr. Ravi Verma, and Dr. Rupa Dutt, and I'll be moderating today, and I'll introduce all of our panelists in just a moment. Just before we begin, just some tips on using the platform. There is, as you can see on the slide here, the biggest takeaway messages are to please use the Q&A as well as the chat discussion board function in the session. So when we're doing the audience Q&A, please put your questions in at any time, and then we'll review those when we're doing that. So let's move on to our introductions today. So I should say that I'm Rosemary Morgan, and I'm based at the Johns Hopkins Bloomberg School of Public Health in the United States. And a lot of my work is predominantly on gender and health systems, more recently gender and COVID-19. And I've been working with Dr. Rosalind Steege at the Liverpool School of Tropical Medicine on a review on gender and universal health coverage. So looking at the literature, what specifically does the evidence say about it, which we are writing up now. But our panelists today, which are all providing some really unique perspectives, you can see on the screen. So we have Dr. Sarah Sally, who is an associate professor and dean of the School of Gender Studies at Makerere University in Uganda. She is a social scientist with a PhD in international health studies. One of her most recent publications reviewed the impact of 30 years of neoliberal reforms on health access and the questions of citizenship therein. And coming from Uganda, she brings onto the panel a voice from the global south, discussing the challenges of attaining universal health coverage in context of poverty and fragility, and why paying attention to gender equity could be an opportunity to overcome this challenge. Next, we have Dr. Ravi Verma, who's the regional director of ICRW India. Dr. Verma has been selected for his work on men and boys and how aspects of masculinities act as a barrier in both seeking and providing health services. So during today, he'll be drawing examples from his experience in India, both in relation to sexual reproductive health, family planning, as well as, I believe, COVID-19, and will present the case for engendering the health system. And Dr. Rupa Dutt is the executive director at Women in Global Health. So Women in Global Health launched the 7th Ask campaign and co-convened an alliance on gender equality and universal health coverage with 107 organizations from 50 plus countries to ensure that the HLM and political declaration on UHC had women's rights, gender equality, and women's leadership as core aspects on the agenda. So she's also bringing the perspective from the civil society and the importance of engaging the civil society at all levels to ensure that the Leave No One Behind agenda is achieved. So here is our session overview today. We're going to start with a moderated question and answer session, and some of the panelists do have some slides they'll be sharing during this session. And then we're going to move on to the audience Q&A. So if you have any specific questions, please do put them in the discussion forum, the Q&A box on the platform, and we'll be reviewing those and have a chance to ask all the presenters. So I will stop sharing and start with our first question for the panelists. So the first question is going to be asked from everybody. So how does gender inequity affect efforts to achieve universal health coverage, and why is gender equity critical for UHC? So I'll say that one more time. How does gender inequity affect efforts to achieve UHC, and why is gender equity critical for UHC? So basically why we're here today. So I'd like to start with, let's start with Dr. Sarah Sally. So over to you.
So good evening, everyone. So briefly, how does gender inequity affect efforts? I think one of the problems and challenges we've had with our healthcare systems is not paying attention to the most vulnerable. So not paying attention to gender equity goes hand in hand with not paying attention to many issues of vulnerable people. And as a result, you end up with a healthcare system which reflects and responds to the need of the rich. For example, Uganda's healthcare system is heavily curative biased, and given the context of privatized healthcare, it serves those who can afford it. So looking at gender equity forces the healthcare system to respond to issues of universal health coverage. For example, one, by demanding for gender disaggregated data, which is important to show where the gaps are and where the successes are. And that way, beginning with gender, then it has forced the system to look at other issues of vulnerable persons. So it is important to pay attention to gender equity because it forces us to look beyond just gender to other issues and political economic issues that drive the inequalities in health. I think I'll stop it there for now.
Great, thank you so much, Sarah. So let's go over to Dr. Rupa. Please share your experiences.
Great, thanks, Rosemary. And what I'm going to do is actually, I'd like to share some slides as I talk about this important experience of why gender equality matters. So just give me 1 second here. And we're just going to go into, so particularly from a women in global health perspective, one of the main things that we really started seeing when the discussions around universal health coverage were happening at the global health level was that most of them were gender blind, and particularly the voice of women and women's perspectives were being left behind. And if we want to truly be universal, as universal health coverage says, we must make sure that we put the U into universal. And that's what's really inspired a lot of the work that Women in Global Health is doing. And why gender equality matters for universal health coverage. We know that particularly women and girls, especially from marginalized groups, are the hardest to reach. And for universal health coverage, we know that if we approach the gender as a cross-cutting issue and look at gender as a means to address all the other aspects of identity and different social stratifiers, and look at power and access to health and apply truly an intersectional lens, we will then only achieve universal health coverage. But if we don't look at those issues, we're going to leave behind an entire population of girls and women, but also others from marginalized groups. We also know that women are majority of the world's poorest people. They're the least able to afford health services. A lot of the work that they often are doing is in the informal sector. And many women have had to create cash insurance pools to be able to provide care for themselves, their family members, or even at the very last aspect of life, to pay for funerals and all those type of things. And we know that women are entering into poverty at higher numbers than men when it comes to health services. We also know that women and men have different health needs throughout life course, and especially when women are in that period of pregnancy and particularly maternal neonatal care. I'm really delighted that Dr. Verma will cover the other aspects related to men and men's masculinities, because when we talk about gender equality, it's not just about women's issues. I'm emphasizing the perspective from Women in Global Health, but clearly there is a spectrum of genders. We also know that gender-based determinants of health drive risk and ill health based on gender roles. We know that men's risk for death, disease, tobacco use, and suicide, and I'm sure there's more to come on that from my co-panelist. We also know that prevention for gender-based drivers, ill health outside the health sector are critical, and that is why universal health coverage is not just meant to be for the health sector to drive, but health-related sectors to really have a critical role, and that is where having a gender approach is really critical. And really, when we talk about universal health coverage, leaving no one behind must be grounded in human rights and rights for girls and women. And we know that there has been an active backlash and attempt to roll back sexual reproductive health and rights, which impact girls and women disproportionately. And this is why gender equality really matters for universal health coverage. Back to you.
Thanks so much, Rupa. And Dr. Verma, Ravi, please go ahead. So why does gender equality matter for universal health coverage?
Thank you. Thank you for having me on the panel. And thanks, Sarah and Rupa, for having said everything that had to be said. In fact, there's really nothing left for me to say anything new on why gender equality is or equity is critical for universal health coverage. Um, all I want to do is to reiterate what has been said by Sarah and Rupa, and to say that the framework of universal health coverage is to ensure social protection and in a sense, human rights and gender equality. So uh, the, the, the philosophy, the basic driving idea for universal health coverage had always been to reach the last person on the mile. That's SDG 5. And we know that in that sense, the entire health system, and Geeta Sen and others have done a nice review of how gender matters within the universal health care, talks about how gender is the fulcrum on which all the pillars of the health system are leveraged. The governance, the finance part, the medicine, technology, the health delivery, how it is delivered, the quality of care, and others. So, and the intersectional lens tells us that gender in conjunction with other marginalizing drivers really makes it extremely difficult for the most vulnerables to access. This is what the point that Rupa and Sarah alluded to. So if we don't use gender lens for each one of these pillars of the health system, we will not achieve the objectives of universal health coverage. So we must look at the gender equality or gender equity not only as an outcome of universal health coverage, but also as part of the process. So it's a kind of a vicious cycle where both the measurements of the outcomes and the processes need to ensure that all the pillars of health system are gender aware, gender sensitive, and the programs are implemented, conceptualized from a transformative lens of gender, and that's the power analysis at every stage of the health system. So if we don't do it, I think we will not. And I'll in the next round, if you give me time, I can show you that how gender blind programs have over the years have ignored the right kind of data gathering on this, right kind of program designing that address these issues of inequality and inequity. In fact, in the COVID-19 time, we are tracking COVID-19 for 187 countries. And I'll come back maybe later. I don't want to consume all the time, but just in a brief, that very few countries are really collecting and making public gender sex disaggregated data on the continuum of the clinical continuum of COVID-19. And that has a serious implication, in fact. So I think, this is something that is a foregone conclusion from the time of Beijing and post SDG. We have been struggling to situate gender or center stage gender in the universal health coverage. It's high time that we take it seriously with COVID-19 coming in and impacting and exacerbating all the inequalities and inequities. So I'll stop here.
Great, thank you, Dr. Verma. So I think you brought in some important points there around the current context that we're currently living in, and thinking around how COVID-19 has actually may have disrupted some efforts to achieve universal health coverage. I think universal health coverage was most certainly on the world stage. All the global actors were advocating for universal health coverage. Many countries, especially low and middle income countries, were on the path towards universal health coverage. So now what I'd like to do is kind of turn to that lens, thinking about like the current context, because I think everything we do from now on, we are going to have to factor in COVID-19 and how COVID-19 may or may not have affected efforts. So Dr. Dat, I'd like to turn to you now and ask you, in your opinion, how has COVID-19 affected efforts to achieve gender equity in the context of universal health coverage?
Great, thank you, Rosemary. And there's a couple things to really ground COVID-19 and really the gender inequities. One, we know that COVID-19 has spotlighted already existing inequalities in our society, and now it is taking an additional, what we call the silent pandemic, and it's widening gender inequalities and broader societal inequalities. And in efforts to really accelerate the agenda on universal health coverage, we know that the global community has been stunted. In many ways, the plans to roll out universal health coverage, national plans to really make progress in the commitments that governments made at the high-level political declaration at the UN General Assembly in September 2019. A lot of those plans have been all put on hold. Parliaments around the world have been put on hold, and that's clearly making an impact on the progress needed in UHC and the progress within UHC that was promised really to address the gender implications. And then what I'd like to do is just really highlight a couple things that we are seeing in the COVID-19 context when it relates to women in the health workforce and the gender implications. And I'm just briefly going to, again, share my screen for these points here. So give me 1 second to put this back up again. And again, I'm pulling a lot of this work really from Women in Global Health and Women in Global Health partners that have really mobilized around the world, and many of them here on today's co-panelists on what are we seeing, what are we hearing, where are the gaps. So an area I'd like to really highlight is that, the agenda for achieving gender equality and particularly gender equity in the health workforce has been really worsened. We are seeing that while health workers are really feeling that they are supported in the sense of being recognized and applauded, but they do not feel supported as far as pay. They're having increased exposure to violence, lack of PPE, having really long hours, very hard working conditions, having to task shift. And in some places they're being stigmatized as being the vehicle for the virus. We know that they're facing higher levels of mental stress. And part of the universal health coverage agenda is to protect all health workers, especially 70% of the health workers who are women, and to really approach it from a gender sensitive ways, how the political declaration has agreed to that language, but we know we need to be gender transformative. And COVID-19 has worsened this and demanded more. And there is a tendency to go back to gender norms and roles and say, women just like to care. And so they're happy to do this for free, which is, we know that's not the case. They want to be compensated. They want to be protected. They want to have a voice in leadership. Women's unpaid and underpaid work already is half of women's contributions in the health sector. We know this is increasing. We also know that, particularly frontline health workers, community health workers who are not counted part of the health system are not often paid, and the COVID-19 has just again further exploited the poorest women, and the poorest women are subsidizing health and care for all of us. When we take a look at women in decision making, we did work taking a look at 87 countries, 115 task teams around the world, and 85% of those were majority men. Less than 5% had gender parity, even though we do know there is a recognition of women's senior leadership at the head of government level being a different approach, a more collaborative approach, more evidence-based, more empathetic. We know these are too few stories, and the reality is majority of the agenda is set by men at all levels of health and broader society. Gender blind health systems, we estimate based on the UNFPA projections and Global Fund and WHO and World Bank that we know that the cases of FGM will go up, and they are going up. Unattended pregnancies will go up and are going up, and gender-based violence. Women are losing access to contraceptives. I won't talk too much about the sex disaggregated data, so my co-panelists can cover this a bit more. But particularly, we know that our health systems are operating gender blind, and COVID-19 has become an excuse to operate blind. Yes, there's more recognition and talk, but is it really resulting in changing the structures that are meant to be gender sensitive by the UHC commitment? And again, at Women in Global Health, we call for gender transformative, so really rooting out the drivers of inequity. And then particularly we launched our 5 asks, which we felt were the areas that were glaringly missing. So equal representation of men and women, safe and decent work conditions, fair pay, shared unpaid work, gender responsive approaches, and really having well-funded women's organizations that are driving this response at the front line, not just when COVID hit, but we know that women's organizations are providing resilience in their communities, especially women's community health worker groups are critical, and they're the least funded in the landscape of gender equality and overseas development assistance. So I'm going to turn it back to you, Rosemary, but just, in closing, I'd like to say we still are, having to, we still don't know the exact impact from a gender perspective. This pandemic is unfolding itself, and really applaud you, Rosemary, for the COVID-19 and gender working group that you convene that is really capturing all the immense work around the world, and hope you can share a little bit about that, because the real impact on UHC is yet to be captured.
Great, thanks, Rupa. I think you really highlighted also like the intersections there between gender and the health system, and and how COVID-19 is affecting sort of and exacerbating existing gender inequities within the health system. And if our goal in regards to health system strengthening is really to achieve universal health coverage, if we want to promote equity, that COVID-19 is likely going to make this a lot difficult. And as you said there at the end, we just don't know what this scale is. And I'll make sure to talk about the gender and COVID-19 working group at the end to invite those participating today to join and become a member. If we are working on key issues related to the health system and health workforce, which are important components to universal health coverage. We want to continue on this theme about thinking about COVID-19, because we really do need to think, how can we build back better? How can we re-envision the ways in which we are currently working? And we know, as the title of this session, no universal health coverage without gender equity, that the vital importance of gender equity and, of equity in general, when achieving universal health coverage, COVID-19 is going to be disrupting that. So my question to you, Dr. Verma, is in what ways does universal health coverage need to be reimagined as a result of COVID-19?
Well, thank you. I think one of the critical aspects of universal health coverage system is to ensure data. I can just give you, extending from where Rupa left, we at ICRW, together with Global Health 50/50 and our colleagues from African Population Health Center, are tracking COVID-19 data on clinical continuum from about 187 countries. It sometimes goes 190, 187 to 190 countries. And it is surprising, in fact, or it is no surprise perhaps, how gender blind the health system has been, that only 13 countries have reported sex disaggregated data on testing. The 131 countries present confirmed cases by sex, and only 11 present confirmed cases among health workers. And we know how gender is the health worker force, which is almost dominated by women. And then 24 countries report hospitalized cases by sex disaggregation, and 102 countries present death data by sex disaggregated data on death. Now, that means that almost about 41% of the total deaths that have happened during this time, COVID-19, the sex is not known. In fact, in India, about 97% of the deaths, we have no idea who died, you know. Uh, well, Forget about the um, other genders. It's just binary data between men and women also is not complete. Vital registration system is extremely poor, which does not, um, about 65 to 70% of the deaths are recorded, and only about 55 to 60% of the deaths are reported by cause. The cause of death statistics is again very, very poor. So you can imagine that if the data is so much fragile, or it's a big gap, how would you ensure that universality of the health happens uh, using evidence, because the data is missing completely from there. And then so this is I'm just telling you only about the health aspects of this data. But during COVID-19 we have also seen um, working on the ground within the communities that are vulnerable, how and the extent to which a large number of adolescent girls from poor families are at the risk of dropping out of these schools and getting pushed into the early marriages, and are perhaps subject to trafficking in some one way or the other. Also, the women have been disproportionately being pushed into the unpaid care work burden. The masculinization of the communities, because men return because of joblessness or the loss of livelihood, change uh, the entire the ethos, or the context within which health delivery was being offered in these places, or women were accessing some of these services. And the worst hit is sexual and reproductive health services. The unwanted pregnancies went up, the unsafe abortions. There are estimates how serious has been the issue around on those fronts. So I think the reimagination of the COVID during COVID-19 and post-COVID, I hope there is a post-COVID. I think, as Rupa says, it is continuing. We would have a conceptualization of the universal health coverage, which intersects with the other sectors as well. It's just, the intersectoral convergence between education and health and livelihood and economic empowerment. They're critical part of it. Now the new, so it's just not about health system strengthening, which certainly needs to be strengthened. The gender needs to be uh, the central aspects of the conversation, and both in terms of making sure that it gets implemented and measured, but also how does health system, because it is very interesting that this is the first time when health system and demand for health has taken the center stage, and that becomes an entry point for many other sectors to come in and connect with the health, and assess the vulnerabilities of the population. So my sense is that this is a time now to truly think in a convergent, as we use the word convergent programming, is to bring in different sectors together, use data at the grassroots, at the lowest denominator, to define the vulnerabilities and address them in different settings and change the institutional practices. So it is going beyond health. In fact, we are talking about universal health coverage, but our data, our designing of program needs to be out of box now, in the true sense of the term, where we address the vulnerability at the individual level, at the family level, at the institutional level. So that we have always, everyone has been talking about ecological framework, the ecosystem framework, but we have never really translated that into the program. This is the time to do it. COVID-19 tells us, has really shown us how these different vulnerabilities are interconnected. And it is for anyone to see out there on the ground. It's not a rocket science. I think it is just a matter of increasing the awareness, to use that gender lens, which allows you to see how some people are perpetually disadvantaged. Some communities are perpetually disadvantaged and are getting disadvantaged. they need to be brought into the mainstream program through interconnection of education, livelihood, and health by getting women. And I think the point that Rupa makes, and we are all partners in that kind of an effort to ensure women leadership. We have always talked about ensuring that women do need to be positioned in a decision making position in health system and other systems to make sure that this happens with that kind of a lens. And that's how I reimagine the health system to extend itself in post-COVID or during COVID-19 situation now. And we are also, just last word, we are also gathering information on vaccine distribution by sex, and it does also would tell us who is taking vaccines and who is not, and why, and that would be important to factor into this new program designing and thinking. Thank you.
Thanks, Ravi. I think it really highlighted some important points there, especially how both you and Rupa highlighted how COVID-19 is really drawn attention to sort of the cracks in the system and the cracks within the health system as well. And the need for intersectoral response, COVID has shown us that is so important, especially related to health and well-being. And that maybe, as you alluded to, re-envisioning the health system as being something broader. And that we are now in a unique time to, with COVID-19 is a bit of an entry point for us to strengthen the health system, to build back better. So those of us working in health systems, how can we really use this opportunity to do that, to promote, to strengthen the health systems, particularly to promote universal health coverage? So with that in mind, my next question is for Dr. Sally. So Dr. Sally, in your opinion, how could health systems be more gender responsive so as to achieve universal health coverage?
Thank you very much, Rosemary, for that. And thanks a lot to my colleagues, the panelists, and to our attendees. I greet you all. I would like to continue the discussion from where Ravi has just ended it. The whole point and emphasis of looking at the ecosystem of health. And Ravi has made it clear that COVID has forced us to look beyond the health sector, to bring other sectors on board. So my presentation is really going to focus on that, but also to bring in the people. And I don't know whether, Rosemary, you're ready to share my slides. So the second set of slides actually has even the COVID aspects of it. Is that the latest set of slides? Okay, so mainly the key point here, we can go to the next slide. What my presentation is really going to show is what happens when COVID comes to a particular kind of healthcare system. So for us to understand where we are going, we also need to understand where we are coming from. And in those few slides, I have a few, I try to show what Uganda's healthcare system is or was before we went into COVID. And this mainly comes from my work on health as citizenship rights. And what I try to show there is that the Uganda's healthcare system is largely donor funded. So if you look at those bars, at the bottom is where we have funds from the public, funds from the state. And these were, of course, statistics from the early 2010s, but they are still very indicative to date. So you see the biggest financier of health services in this country for the 2 years is donor development partners, and then private funds. Private funds are really the out of pocket for people's, from household kind of expenditure, or maybe where people work from. So can we go to the next slide? This just shows us the kind of expenditure by function. And this was total, whether it was public or private. And basically what it was showing is that most of the emphasis is outpatient care, then followed by inpatient care and preventive care. And the purpose there is really to show that we have less investment or limited investment in preventive health care. So what are we trying to do? We are trying to treat people who are sick, whether it's inpatient or outpatients, but what are the challenges that we shall see later. So we go to the next slide, Rosemary. This was just trying to show the kind of financing by provider. And again, there, the main point is for us to see that when it comes to financing health services, it's really revenue from households over those 2 years that were provided by the Ministry of Health. So others try to finance, but it's not as much. So it's largely revenue from households, followed by employer-based insurance. So can we go on? Okay, and this is expenditure by health services. And again, there it shows most of the expenses are on medicines, whether from private or public, and leaving most of the other things not really catered for. So you have that, then you have other expenses such as transport affecting healthcare service, and then hospital clinics, and then, can we go to the next slide? Okay, so you then look at how much people spend on out-of-pocket expenditure by financing quantiles. Of course, the richest in the society tend to pay more, and the poorest in the society tend to pay less. But if we look at what the poorest are paying, 1,100 shillings, 1,103 shillings per capita income in 2011, or 1,236 in 2012, by that time was just 50 cents. So that shows you what actually the poor are able to pay for healthcare vis-a-vis the rich. So when we are talking of universal health coverage, how much can we talk about universal health coverage in such a context? Can we move on to the next slides? Oh, that was the end of the slide. There's one I had sent which had some of the COVID-related kind of statistics, but I think it came in later. But basically, the purpose of that is to show us that already, before we even talk about COVID, even when the rhetoric for universal health coverage has been on for a long time, the healthcare system looks like that. So then we go into the COVID statistics. The COVID statistics, oh, sorry, you've been able to do that. Thanks a lot, Rosemary. So apologies for the confusion. Basically, the COVID statistics, again, are general, but they show us the context of the ecosystem in which health is operating. If we are seeing a healthcare system largely financed by households in a context of a community where most households are poor, and maybe the other statistic you need to know about Uganda, we are one of the youngest countries in the world. By that time, 67% of the population was aged 15 and below, and 87% now is under 35 years. And you're talking about a largely privatized healthcare system, which is financed by the household. How much universal health coverage can we talk about? So boom, 2020, February, we then get saddled with COVID. And those are some of the issues that COVID provided us with. So we have challenges related to healthcare, but many people losing jobs. And so we have high rates of suicides. But if we go to the next slide, is where you'll see the very gender-related ones. Early pregnancies likely to come in. Domestic violence on the rise. But the big issue that the country is grappling with now as a result of COVID is the teenage pregnancies that arose by keeping the girls long at home. Okay, and then what happened in this COVID is that we did try to write out certain effects. And one of the papers I published in the COVID situation, or during the lockdown, related with some of the effects. And in one of those papers, I observed that COVID came in a context of an ailing healthcare system. An ailing healthcare system in which we could not talk about universal health coverage, and in which we could not talk much about gender equity, except in providing services such as maternal and child health. So one of the things that we had then, as a result of the lockdown, some of the gender defects we document, is that we had a declining use of healthcare services, because one of the things was that the stigma and the threat about catching COVID made it difficult for people to go to the facilities. But on the other side, you had travel suspended, hospitals emptied of what was considered non-essential healthcare services. So people then needed permission from political leaders to access healthcare. One of the things that was a big after effect of that, and the direct one related to accessing healthcare services. Because you had, by the time mothers went through hiring or walking long distances to access healthcare or to access transport, and the border, those are the bicycles that would have transported them, were not able to do that because they didn't have the permission to move. So most poor mothers were encumbered by long distances, and by the time they reached health facilities, it was too late. So during the COVID lockdown, we registered many numbers of mothers dying, an increase in maternal mortality. During COVID, we also registered an increase in reduced use of healthcare services, and this largely related to, even if not maternal child health, but what was considered essential excluded things of requirements or people who needed routine health care to do with diabetes, with heart failure, and things like that, HIV, and where there were gender issues like to do with HIV, we ended up with people suffering. And as Ravi has said, a lot of these are not yet accounted for. So when we came to the healthcare providers, we had health worker challenges. Ravi and Rupa have already commented on this. Most of the lower cadre healthcare workers tend to be females, and there were issues of access to protective equipment for them, but also access to transport, because as I portrayed earlier, an ailing healthcare system which doesn't have a public transport system, except a few ambulances for private facilities, also created challenges of transportation for health workers, especially the lower cadre health workers who could not afford cars. And then, of course, I've already commented on issues to do with sexual violence and the gender-based violence and the lack of evidence for that. First of all, how do you access healthcare services? And also, what evidence do you produce in case you need? Because also the courts were suspended, except for the very critical cases. Later on, the police tried to make it more accessible for people to report using hotlines of domestic violence. But if you're reporting domestic violence using a police hotline and you're living with this person in the house, it may not be very easy for you to get that kind of call. So I've already commented on that, but on teenage pregnancy. But the thing we have to remember, all this occurs within a context of employment and job losses. So in a context of employment and job losses, where healthcare facility services have to be financed from the household, that means households will become more constrained to access healthcare because they do not have the money with which to pay for the out-of-pocket. So what kind of universal health coverage can we speak about in such a context? And in such a context, how much can we pay attention to gender equity? So there are all these challenges we have to think about. Of course, I remember, and I agree with Rupa and Ravi, that if we can begin documenting these matters, it will be very important. Then it will show us where the challenges are and how gendered those challenges are. And another important point we need to go away with is that when we begin paying attention to issues of equity and vulnerability, we shall be able to pay attention to other issues that COVID has showed us, such as higher rates of suicides by males. And what does this mean to a household? And what does it mean with regard to accessing healthcare for a poor household? It is also very important. What COVID has also showed us is that you cannot think about health in an abstract or out of the ecosystem that Ravi talks about. The healthcare system is within a larger political economy analysis where you have to think about the other sectors, but most importantly, you need to think about the people and the relationships that drive the people. And in that context, it is very important to pay attention to gender and the issues of intersectionality and vulnerability, because it's only when we do that that we shall be able to build a responsive healthcare system. Thank you very much.
Thank you, Sarah. I think you as well as Ravi and Rupa have really highlighted the fact that COVID-19 has very much changed the landscape, that we're all working in and that we're all living within, and especially within the health system, changed the landscape towards our affecting our efforts towards achieving universal health coverage. And I think we can, use this potentially as an opportunity to build back better, to make health systems that are more gender responsive. So the question I'd like to pose to all of the panelists now is, with this in mind, if we wanted to create gender responsive health systems, what does it mean to take a gender lens within health systems, within universal health coverage? What does gender responsive universal health coverage look like? So I'd welcome all panelists to, turn their video cameras on, because right now we'd really like to foster a discussion, and then I'd like to very much encourage the participants to please put your questions in the question and answer box. Think about what you'd like, anything specifically you would like our panelists to talk about. And while you're doing that, again, what my question is, what does gender responsive universal health coverage look like? What does it mean to take a gender lens in regards to universal health coverage? And maybe Sarah, maybe we can start with you.
Okay, so what does it mean to have a gender responsive universal health coverage? One, as Ravi says, we shall need data. Okay, what services are going to be provided and for who? And this data is not just about the healthcare users, but also the locations of where the facilities are. So data is very important. Number two, we need to analyze the services. We need to analyze people's ability to access these services. And in this case, we are not just talking about the location of the services, but the ability to access the services as per the unique challenges of the different countries. For some countries, it will only be transportation. For a context like Uganda, you're talking about transportation, but also the ability to pay, but also not only the ability to pay, where people have religious differences, you also need to talk about who within the health facility is going to be able to treat these people. Is the workforce gender balanced? And then you also need to tie all this together with the financing aspect. Who is financing these services, and to what extent is gender factored in the financing bit? Because without gender, then the financing, the provision will not add up. Thank you.
Thank you, Sarah. Ravi, would you like to give us your perspective?
Sure, thank you. Well, what COVID-19 data, the the clinical data, fragmented, inadequate, insufficient data, tells us profoundly, and I'm substantiating that with our own experiences on the ground, that larger gender equality or the extent of patriarchy in a place determines the health outcomes. Now, let me give you an example. So in a highly gender unequal society, in fact, there will be more men dying or getting exposed to the infection, because they have pushed women into the households to take care of all the unpaid care work and bear the burden of the households. And they are outside, and because masculinity norms suggest that they are the ones to be going out and working, and they're getting more exposed, and they're not getting tested. They are not using social distancing. They are not following them, all this safety. So in a very unequal society, men may be more exposed for the masculinity norms of this kind. On the other hand, in a highly gender equal societies, women may be exposed to more deaths and exposure, because they are following masculine norms there, because they are exposing themselves through the smokes, they are drinking, they are, the whole the norms that determine their behavior is again that universal norm of gender, which pushes certain ideas which are desirable for a society moving. I'm just making a point that unless we look at gender as a construct that determines the nature of power relations and what gets valued and what doesn't get valued in a society, we would not be able to address neither the health outcome nor the other equities, because both are vulnerable in the same way as both men and women and other genders. I'm talking not about other genders now, but both are equally exposed to the same risk if the gender norms are not changed, those fundamental norms. So I think, how does universal health coverage or health system looks like to answer your question? I think or what it should be doing, I think it should be raising the bar to address the normative issues. And when I say that, I think this is something which has been put under the carpet completely. Though it's a difficult, it's not a low-hanging fruit. It's a difficult thing to do, to change the gender norms in societies, in challenging the unequal relationships by bringing both men and women into the same discourse and challenge them together. Whether it is a highly gender equal, so-called gender equal societies where the workforce participation rates may be equal, where the life expectancy may be, women may be higher, but even there we have seen that death ratio is very interesting, where somewhere in the highly gender equal countries, sometimes women are dying and getting exposed more than, and in some societies, men. And it is essentially because gender relations and gender norms followed there are determining these outcomes, and that need to be addressed. So I think a transformative approach to health system requires that we don't only restrict ourselves to addressing health system. Because health system is also embedded into the larger system of norms that are determining people who are running the health system. So if they come with that lens, they would not. We have seen how sexual and reproductive health services have been completely blindfold, or the violence against women have not been addressed in the health system in the manner it should be as integral part of it. There are very few examples of that. So, or violence against other genders. So I think the whole, and violence was never, even if the data is being gathered as part of DHS and NFHS and all, but I don't think addressing violence has been part of violence against women, has been the integral part of thinking within the health system. Why? Because that becomes a private issue. It's according to the normative structure. It is between husband and wife, or the spouses and partners. So I think we need to break that discourse and that is what the universal health coverage would actually do a justice, that idea, that construct, if it really moves the agenda to addressing norms, in my view. Besides everything else that Sarah has said, those are the non-negotiables, when you address that. But I'm saying that the things that have been often talked but not addressed in any tangible manner is the issue of gender norms. So I'm just adding that perspective to what Sarah said.
Yeah, that's really interesting. Thank you. Yeah, it's interesting to hear about the sort of different components and and what we really need to think about when we're integrating a gender lens into universal health coverage. So Rupa, over to you.
Yeah, so I think, the other context that I'd like to say, just framing the UHC agenda, is really what is on the minds of head of governments. And right now, head of governments are still thinking all about the pandemic response, the global health security agenda, and quoting Dr. Tedros here, if we start to look at UHC as, part of the same coin, two sides of the same coin, health security and UHC, I think there is an opportunity that we as health experts, advocates, those working in this community have, as governments are really looking to reshape and design their health systems, but also how their health system connects to other sectors. And, picking up on Ravi was saying there, that not only, when we look at issues in the health system that we feel like our responsibility, many of those that we know are driven by other determinants, whether it is the social determinants of health, the political determinants, the commercial determinants. So really, when we are trying to address the gender equity aspects in universal health coverage, we as a community that are working in gender and in health systems work really need to also, look at those other sectors, start building relationships, bringing them into our discussion, and they're more willing to actually have discussions on health today than they were a year ago, because now, health is on everybody's minds and it's affecting every sector, and merely making sure that the gender transformative discussions are beginning. And the second part is really looking at this agenda not just as SDG 3 on health and well-being, or the part of SDG 3 which is part of UHC, but really seeing that working with on UHC, but from a gender perspective, really does lead to multiplier effect in achieving many of the other health, many of the other SDGs, which we might not associate it with health. So like, for example, ending poverty. We know that UHC is the one vehicle that can at least reduce one of the key drivers of why people end up in poverty, who again are majority girls and women. And women might live longer in society, but they're often poor. Many countries don't have laws that protect inheritance or protect pension, or when women in high-income countries take leave to provide childcare or elderly care or family care, they don't get pension benefits while their counterpartner does get pension benefits. So the inequity in economics is huge, keeping women, pushing women into poverty over and over. And again, if that's one SDG I'm picking up on, but we can go through all of the others, and it would be very similar, looking at quality education, looking at decent work and economic growth, reducing inequalities. And we can even argue that, peace and justice is also critical in partnerships. So really looking at this agenda and encouraging all of us that are working in gender and in UHC to really look at this particular opportunity. And it might mean us, using translation and choosing words that we might not necessarily use, but have shared meaning, or at least enough commonalities to have a shared discussion on. So really the other challenge is, let's also adopt the language of those that do have the political power and influence in other sectors to drive the agenda. Back to you.
So I'm just hearing all of you speak, and just wondering, are we being idealistic? Is this really something that we can achieve, right? Within, like, thinking about health systems and who leads health systems, right? Particularly, and thinking about gender equity is something that's, we've been calling for a long time. We've made headway, but we still have so much to go. Are we being naive by advocating for gender equity alongside universal health coverage? Who would like to take that first? Sarah, please go ahead.
Yes, thank you very much. And it's an interesting question because it acknowledges the reality of where we are. In most settings, of course, health on its own even doesn't rank highly, does not compete as favorably as defense, as trade, as industry. And then, of course, within that whole mix, we've been talking about gender equity and gender equality for centuries. I mean, people before us have spoken about it, and people after us are going to speak about it. But I don't want to think that we are simply wasting time, because indeed there have been achievements over time. They may have been slow, but they have been there. For example, the focus on maternal and child health came out of debates on women's peculiar needs and gender concerns in the healthcare. So now we see some kind of attention even within the healthcare system to pay attention to maternal and child health, to safe deliveries, to obstetric care. We've seen attention being paid now to women healthcare service providers in terms of basics like housing and priority to access to basic housing near the health facilities. We are now seeing attention being paid to things like accessing a hospital bed for mothers in labor, but also for people with disabilities. So there's a lot that is occurring. We are now seeing attention being paid to teenage pregnancies. There's now attention being paid to men's health, especially with regard to mental health, with regard to HIV, with regard to issues of trauma and things like suicide. So I don't think we are wasting time. Gender equity can be achievable. And as I said in the beginning, gender equity and the demand for gender equity in health has been one way that societies and governments and policymakers have been forced to look again at a sector they assumed was helping everybody, because health is loved by everybody. There should be no concerns. But the emphasis on gender equity has forced actors in health sector to the global level like WHO, but from the local level like our local governments, to say, let's look again. How are women faring? How are children? How are teenagers? How are disabled people? So I think we're on course. It is a long journey. but we've started. We shouldn't lose hope. Thank you.
Thank you.
Well,
Ravi, please go ahead.
yeah, Rosemary, I don't think we are being idealist. I think it's our moral commitment. The universal health coverage is, as I said, talking about social protection or human rights for those who are vulnerable. It's not being idealist. It is a matter of ensuring that we live in societies that respects each other and ensures that that respect is translated, uh, respect and safety that's translated into the programs. And I think from that point of view, if we have that lens, and I think we should have that lens, we find ways, and there are many examples where frontline workers, the officials, the policymakers, the civil societies have all made genuine efforts to promote gender equality, to ensure equity in the systems. And I think we have to learn from those experiences, and we need to protect people and also make sure that they are sustainable. These mechanisms are sustainable because there's an investment into them. We can't really be in a project mode all the time. We need to, and that's why if it is a idealistic dream, I would rather have it, because I think this is our responsibility at this point in time. We need to have that vision, and we need to translate that vision, and the whole lot of work has happened in terms of indicators development, in terms of measurement. The methodological innovations have happened, that people using combination approaches, they're using different health system strengthening approaches. So my sense is that we are already working hard on these issues. It's a question of taking one step forward, two step back, and a larger. If we don't really push the boundaries, then we constantly remain within a certain threshold. We don't break that threshold, and this is a high time we begin to break that threshold.
Well, you're all giving me a little bit more hope, but still, sometimes, the moral arguments just aren't enough, right? They're just not enough. Like we say gender equity for gender equity's sake, people aren't often listening. So yeah. Rupa, what do you think?
Yeah, I think, well, I would say not, I know that there has progress been made in gender equality and achieving our health equity goals as well. It's slow, it's not fast enough, and progress is there, and we do have to recognize that the drivers of gender inequity are rooted, as one of my friends once told me, it's even before you're born that gender is already influencing your life. And we have to look at it from a generational timeline. It takes generations, and I know all of us on this call know this, but we know that there's also bigger societal issues that we also are seeing that are similar in many ways, where you look at the climate justice movement, and it can also be very grim. But if we make the investments today, and if we start transforming our systems today, then we have the opportunity to influence current generations, but most importantly, future generations. The second, I think, aspect of hope is I love these, predictions on like how long is it going to take for gender equality, because the numbers can jump so dramatically. Like the World Economic Forum has made a projection that it was going to take 200 years, and then a couple years later they released another one. It's going to take 100 years, and when there was a very conservative government here in the United States, the projections went skyrocketing the other way. So there's a lot of movement and flexibility. And then the third part of it is also grounding it on the hope that I get from all of the women in global health community. And I consider that all of the partners here on the call, but also a lot of the chapters that have formed and the women that are now, really pursuing that pathway for becoming, formal leaders, top leaders, decision makers. They're driving the change within their community. And that gives me hope that there is this, even we know there's always been talent in the health workforce, but now there is also this catalytic collective action drive. We are in a way ready to protest together for these changes, and I think that is new, and that also really gives me hope.
Sarah, please.
Just one small addition, and this really should give us hope if we take Ravi's aspect of looking at the ecosystem. Of course, if we just look in health and health, there will be a challenge, there will be disappointment. But if I'm to take the example of Uganda, in Uganda now you cannot, we have what they call gender equity indicators. And so if you look beyond the health sector to what is happening within the economic sector, there is the wider aspect of gender equity certificates within the whole concept of gender budgeting. So in the health sector, unless people have shown that they are paying attention to some gender issues, they cannot be funded. And this goes all the way from the lowest level to the highest. You find even people who cannot speak English, but struggling to find out how do they make their budgets gender sensitive, especially within the health sector. I think the issue now is for us to provide more toolkits and more manuals to help this to be actualized, because there are many people being charged with doing gender who do not have that. Otherwise, we're on course. So let's have more hope. Thank you.
You know, Rosemary, just quickly to tell some of the programs we have in Pune. We are in remote village areas. We are experimenting with the idea of convergent planning, and we have, together with the local governance system, panchayat as we call it, they, with the health system, education system, have created village level convergence committees, which is different from all other forums of self-help groups of women and panchayats, governance structures, and block level development committees that are usually as part of the government system. This forum platform of convergence committee brings different sectors together, uses local data. You know, they map the local all the demographics and social and economic situations of each family, and then they discuss every quarter together with them, together with the members of the governance, the government governance system, and the civil society, other civil society forums, to see how they would use that data to reallocate the resources at that level. So I think a lot of it has to happen at the micro level rather than waiting for the big policy and move to shift. My sense is that if the civil society groups come together, and a lot of the places where civil society organizations and the women's groups, especially women's groups, self-help groups, microfinance groups that have become extremely viable platforms to integrate some of these different sectors together and weave in a common approach. It's just that they need data at the local level to make sure that when they are making a decision, it is based on the evidence and the rational follow-up of what the impact is. So it is doable. I mean, and there's an energy, and there are women and girls at the local level who are educated, who don't have, if they have not gone outside the local village or local areas, they have become the mentors of these platforms to bring the data to gather information. I think we all have a responsibility to galvanize this kind of localization of this global ideas, and collective formation. And that's possible because the experience in collectivization has been mammoth. It's a huge experience on the ground. That needs to be the strength for taking this forward. So I think that's a hope.
Yeah, that's a nice point about, the importance of bottom-up grassroots movements. I know women's collectives in India have been particularly strong and impactful. And I'd say you all are giving me a little bit more hope. I mentioned the review that Dr. Rosie Steege and I are doing on looking at gender and universal health coverage, and the data is fairly depressing, I'd have to say. Like it's more arguing for the case of why we need a gender approach, that thinking about what services are covered in relation to universal health coverage, like what's part of financial packages, how many services are actually missing for women. Often you're looking at maternal health, maybe some sexual reproductive health, but often not the more controversial sexual reproductive health, even like contraception, access to abortion. And then thinking about women outside the reproductive life cycle is like they don't even exist, you know, children and older women. And then thinking about, you know, around what are some maybe sex specific needs of men, you know, because both men and women have specific needs. Thinking about, you know, that's also like what services are covered, what's included in financial packages, the idea of like out-of-pocket expenditures and how women are paying often pay so much more than men. That's what a lot of the evidence is saying. And then also like thinking about coverage, the proportion of the population that's actually covered and able to access, thinking about how gender is impacting both like access and utilization of these services. You know, and I think that the data is really showing this absolute need for this gender lens, more so than you know, good examples of gender and universal health coverage, of gender responsive universal health coverage. We only have 5 minutes left. So what I wanted to do is just go around and just let each of you to be able to say anything that you wanted to say to wrap up. And if you just each keep it to a minute or less, please. And maybe I will start with Rupa this time.
Great, Rosemary. Well, foremost, I just want to say thank you to my co-panelists and for you for moderating this session. What I'd like to say is we must keep the promise on gender equality and for all girls and women, but actually all genders, and really keep the promise to mainstream gender, keep the promise to integrate SRHR, keep the promise to protect our female health workers and enable them, keep the promise to really ensure that women's unpaid work in the health and social sector no longer is the case, and make sure to keep the promise to fund women's organization. And finally, I think the most critical one is to make a promise to have women's voices and leadership at all levels of UHC, and making sure that that becomes an avenue for diverse voices from all different backgrounds.
Thank you. Ravi.
Well, thank you. I would also like to echo thanks, Rosemary, for keeping us galvanized and glued, and my co-panelists, Sarah and Rupa, for very insightful comments. My one sent, I don't want to repeat, but reiterate that the discourse around masculinities within the health system is critical. We have, if we have to change the face of the health system and how it functions, then we must recognize how masculinized the health system has become. The entire training, the medical education, the preference for different, you know, disciplines, and how doctors and nurses and the health workers are organized around, you know, hierarchies. I think the very hierarchical, masculinized system health system is, and that needs to be broken. And I think we must find ways to bring that discourse within the health system as one critical aspect of establishing equitable health service. There's so many other things, but I think this is the lens that I would use as a masculinity lens. I would really narrow it down from gender to masculinity, because I think masculinity norms are the ones that are different from the norms around equality. They operate in isolation in how men relate to each other and how men draw their you know, sense of entitlement and operationalize them. So, but nobody questions them because they are in the position of power. So I think it's high time that we take the bull by horn. I think I'm using the wrong phrase, but I mean it, that it's a invisible elephant, as they say, that patriarchy in your own system, which needs to be addressed within the health system.
Mm-hmm. Yeah. Thanks, Ravi. And we do not advocate any harm to animals. No taking bulls by horns. No. But I like the invisible elephant in the room, which analogy. And I think you raised some important points. And when we're taking a gender lens that we really need to consider. And Sarah, over to you.
Yes, thank you very much. And I think for me, the thrust really is around having right data and improving financing. And women over time have advocated for gender equality in all aspects, including health. And unfortunately, we've tended to think because they are the most suited for that, we should leave it to them and women should do more. And indeed, they're going to do more. But we also need to look at the other side of the coin. The biggest financing is with governments. At some point in this discussion, Ravi's talked about the whole point of sustainability. So women's groups, civil society has done this much and has to continue doing more with advocacy. But it's high time governments picked up the message of gender equity and equality as a way of effecting the message of universal health coverage. Most governments have signed up to universal health coverage. They have signed up to a number of WHO conventions. So if gender equity is one way of achieving that, they need to do this very well. And that's why, to an extent, I celebrate the Ministry of Finance strategy in Uganda to conduct gender equity budgeting. Again, it was an effect of women's organizing. So we appreciate the women's movement for that. But out of that and through the parliament, the Ministry of Finance assumed and the role of gender equity budgeting. And within the Public Management Finance Act of Government, you cannot have money drawn from the consolidated fund. You cannot have your budget financed without showing the gender equity indicators and planning for gender equality. So there's still a struggle there, given that most civil servants don't know what gender is. Most of them are still resistant. Most of them still have those norms that Ravi is talking about, which are still problematic. But time and again, they've taken their budgets to the Ministry of Finance for funding, and the Ministry of Finance has thrown them out for not being gender sensitive. And then they return and say, okay, what does it mean? Is it adding a few women or whatever? And health being one of the sectors that is paid attention to from the national level to the local government level, the parish level, it's important that they tend to show these kinds of things. So what am I saying? We should still continue pushing for gender equity. And as we pay attention to norms, we should also pay attention to issues of financing and financing beyond maternal and reproductive health, because you will not find data on malaria indicators and other things. And yet those are the things we deal with every day. So you will only find data on obstetric issues. And then people tend to think, oh yeah, since we dealt with reproductive health, we finished. But we shall need the gender disaggregated data in all the other sections, but we shall need financing for health to improve beyond the households. Because as long as it's kept at household level, it falls in the trap of norms and other kinds of gender inequalities. So thank you very much.
Thank you. And we're nearing, we're just over about a minute or so, and I just want to really thank our panelists. And, I think you've really highlighted the interconnection and interrelatedness of gender equity, gender inequities, and our ability to achieve universal health coverage, because equity is such a strong component of that. You really all advocated for taking, a gender responsive, gender transformative lens. And also how we're in quite a unique opportunity at the moment to really galvanize, on the situation that we're in with COVID-19 to really build back better, to build systems that work. It's really shown where existing inequities lie. We're able to hopefully now address those. And you've all provided some good solutions of how we can do that. And thanks, Sarah, for ending on a really concrete example of Uganda and then, thinking about gender budgeting, which is such an important component to universal health coverage. I think in a lot of the articles that Dr. Stege and I are reviewing, so many of them are related to financing. Like when people think of universal health coverage, they often think of financing. But so that's such a huge component, but we also must think, as you said, think about what services are included and, whose ability to access them and who's not. So what I'm getting also from the presentations today is that we still have a lot of work to do. So we task all of you, thank you for joining us today, and task all of you to please take this forward and do within your work and lives, really help to promote the inclusion of gender equity within our efforts to achieve universal health coverage. And with that, I'll say thank you very much and say good morning, good afternoon, good evening, wherever you are.
Thank you. Thank you,
Thanks everyone for tuning in.
Rupa, it was nice seeing you.
You too, and you too, Ravi and Rosemary.